Are the dam's dames here? We're looking for the dam's dame. Chris, would you get the dam's dame?
Don't swear, Peter. Don't swear.
Oh, she's here. She's here. Okay. Just want to make sure that you're all lined up. Okay. Ladies and gentlemen, we are approaching the highlight of this meeting. Not that there weren't other highlights, but here's another highlight coming. Before I introduce the next speaker, we want to give like 5 minutes to the Dental Amalgam Mercury Support Group, which has really been the reason that the mercury issue in this country and in the world is tipping in the right direction. I'd like to give you a little update from my personal view on things. As many of you may not know, but in Europe, things have been slipping backwards with the mercury issue, and it was a very simple trick that the establishment used there was simply by cutting off through insurance reimbursement, cutting off the source of income for the dentist for placing plastic and non-metal restorations and ceramic restorations and other ways. And the whole forward movement that was there, at least in Germany and Austria for a while, seemed to have stopped and has gone backwards. Where more of the dentists that I know have gone back to placing amalgam fillings than it was, of course, before. However, in Sweden, things are still going forward from what I'm observing. And so, but here in this country, of course, I don't know any dentists having lost their license in the last 2 years based on the amalgam issue. Now the whole front has been on the cavitation issue, has become sort of the point where the conservative forces are trying to stop the forward movement, and the amalgam issue, I personally believe, has been tilted very much from the bottom on up by having the Dental Amalgam Mercury Support Group and other movements that came from the population that really have tilted the issue here in the right direction. So with this, I want to give you guys, you've got 5 minutes. Sorry, for the time restriction, but come on up and grab the microphone and say what it is that you have. Hi.
Yeah.
My name is Freya Koss. I'm from the Philadelphia area. I'm sorry. My name is Freya Koss. I'm from the Philadelphia area. I work with dams, and I am here because I was very badly affected by the mercury from the dental filling. But before I go any further, sorry, used to this. Before I go any further, I would like to thank Carol and Ed Arana for giving me and the DAMS organization the opportunity to attend this very rich and informative conference. I only wish that I had known about mercury-free dentistry and the American Academy of Biological Dentistry 2 years ago, before I had a filling implanted in a cavity, which I thought was a silver filling. I developed double vision 7 days later, which followed with loss of equilibrium, droopy eyelids, loss of muscle control, and many other symptoms. Having a mind of my own, which doesn't necessarily serve us well at all times, but in this instance, I believe it did. My stubbornness and tenacity, I think, saved my life. Instead of accepting the magic pill, which was a steroid, I was told it would fix my eyes. I entered the world of the internet and proceeded to research vision and then teeth. Dr. Gordon so aptly pointed out yesterday that the internet is a very powerful tool in learning the truth. Without the internet, I never would have known what happened to me, and probably would be walking with a cane right now thinking I had MS. An English woman on a news group reported that she had MS for 10 years, and the last 2 times she had her teeth filled, she developed double vision 7 days later. That was about 3 in the morning, and I sat there with a patched eye, and that was the clue that solved the mystery for me of a debilitating neuromuscular attack on my body. And so I switched from vision to teeth, and I found way over 100 websites on dental amalgam mercury syndrome, and I got involved in an amalgam discussion group, and that group supported me for over a year. That's where I received my information. The doctors that I was seeing, and there were about 25 specialists, basically labeled me with a variety of illnesses, and I gave them the scientific data, and nobody would look at it. Absolutely refused. And I just got angry, and I knew that I had a mission. And this is my mission. And I have worked steadily with DAMS for the last 2 years. My health has gotten better. It's a very, very slow process. I'm very frustrated by it. I think I never will be well again, and I really don't know. But if it weren't for you people out there, the pioneers who are committed to your research and helping others, none of us would be getting better. And I communicate with hundreds and hundreds of people through the internet. I now belong to 3 discussion groups. It's growing, it's multiplying, it's changing. And many of the doctors and professionals in the audience know me. I've visited them. They've been extremely helpful, and I'm very, very grateful. The last 2 years has really been a relentless search to regain my health. Carol Ward, who is the vice president of DAMS, fortunately lives in my area, and she is the first person I contacted. And she is the first person who said, "You don't have MS. You've been poisoned by mercury." She is the person who really well, I learned from her of the enormous efforts put forth by DAMS to reach out to the public and to offer information and to refer victims to dentists and doctors who can help them. And I have taken over the role of the DAMS internet connection. So I do what they were doing through phone calling and snail mail through the internet, and I hope to develop a website. I've already sent out newsletters. You may have one now, and if not, you can pick it up in the back. My personal story is back there, and I would like to develop the Mercury Free Press, which will be the people's voice. I have many connections in Europe, and I'm continuously communicating with them, and they will be offering research and abstracts and articles in this mercury-free news. So if you'd like to receive this letter, please fill out the form at the bottom of the yellow page and drop it into the bowl at the DAMS booth. I'm going to introduce Ann Ferrara, who is the Virginia coordinator for DAMS. She and I and other members of DAMS have marched on Washington, and she'll fill you in on what DAMS has been doing there and also the need to help us fundraise. Thank you very, very much.
On behalf of DAMS, I want to take the opportunity to thank Carol and Ed Arada and the Academy of Biological Dentists for having DAMS participate as an exhibitor. The conference has been very informative and heartwarming to see a group of doctors that are dedicated and care about the patients. Now, I just want to tell you a little bit about the Committee on Government Reform. Dan Burton, Chairman, is interested in looking into the dental amalgam issue. We need your support to write letters to the Committee on Government Reform. Also, it would be very important to have your patients write as well. The information is in the back. Sorry. DMs need your financial support so that we can continue to educate the public on the dangers of dental amalgam. You can help by buying raffle tickets to win a state-of-the-art computer, be a champion Olympic donor, become a member of DMs. We really appreciate your help and support. Thank you so much.
One of the original strong leaders of DAMS was Merlene Brake, and she happened to be one of my patients in Santa Fe. She lived in Albuquerque, and I'm sort of proud to say that in the early years of DAMS, I was sort of like an important moving force behind the scenes to point them in the right direction of how big this issue really is. It was in the early 90s, you know, when everybody thought Lechner is really like one of those outlaws and like one of those self-important Germans who thinks he's got a message, but really doesn't apply to us Americans, and let's hang him by his feet and toenails, you know, on the next tree. I'm so glad that the times have changed since then. I just want to, just a personal issue. You guys have this yellow sheet on your table here. This is the current legal issue of a very close friend of mine, Madison, from Vancouver. As I said before, the prosecution of, you know, it used to be in the early 90s, it was us physicians who got strangled and, you know, spent our life's income on defending ourselves and going forward with these different issues. And now the forces pretty much have backed off in the medical field and have shifted over into the dental field. And first it was the amalgam issue, and now they're backed off on this one because the scientific evidence is just so overwhelming. But now the dentists are being crucified for doing the cavitation work. Both here in this country and in Canada, the main focus has been the direction. From what I hear also in Germany, those of you who don't know, Germany is an American colony. It is not, you know, we have the American military over there that basically tell us what to do, and the industry and everything is Americanized now, and so we're just, you know, some Germans have retained their own smarts about it, you know, but basically we're an American colony, and so whatever's done here in the swoop zone.
Learned how to raise campaign funds, I understand.
Yeah, you see the yeah, you see the same campaign kind of stuff that you've seen here. So, Madison, why don't you raise your hand up? Madison is a wonderful guy. He's been outstanding in that he's been one of the most open-hearted dentists that I've ever met, who's really been given his all to his patients. And he's not one of the guys who created a huge home and, you know, a sailboat in the sound and all those things. He's kind of spent his money on equipment as he went along. And he decided for a while to give up on dentistry and go to Mexico and, you know, practice there, and then in the last minute he decided to fight it, which I think is the right decision. And so any one of you here, either who knows anyone who's got some money to spend or who has some money to spend, he's a guy worth spending it for. So I just wanted to put that as a personal note. And we don't want any more strokes or heart attacks or cancers as a sort of fallout of this, or even gray hair or hair loss, you know. Okay, with this I want to introduce the next speaker, Hans Lechner, or Johann Lechner, as his proper name is most certainly the most outstanding and well-acknowledged holistic dentist in Europe, in all of Europe. And I've known Hans for a number of years. And Hans trained with Dr. Turk. He spent several years as the main assistant of Dr. Turk, who's also been a teacher of Arana. And really behind the scenes, many of you don't know that the kind of dentistry you practice, or the kind of cavitation surgery that you do, that the surgical procedure, the original guidelines for that were developed very much by Dr. Turk. And Dr. Lechner was his main guy, and is very well known beyond Europe as the surgical hand, like the guy with the best hand in Europe, and who's really pretty much has been the teacher of everybody else in Europe now. He's sort of our generation, and he's been the teacher of everybody. And beyond that, Hans also has a extremely brilliant mind, that, you know, one of those rare things that sometimes emerge in Europe more so than other places. You know, there's some. I don't include myself in this, and I'm very humbly kind of referring to, like, there's a couple of guys here that we've seen over the years, like Einstein was one of them and stuff. And now there's Lechner. And one of the things that made me feel especially close to Hans Lechner is that he went through the same learning curve that many of you have gone through. He's been through all the EAV stuff that most of you have been through. He studied with Boll and with Kramer and all the old guys, and had all that under his belt, and then shifted, just like I did, to a physical procedure. He uses an offshoot of kinesiology. It's called arm length testing. And the arm length testing was introduced in Europe by Raphael von Asche, who is a very common close friend of us, who is a student of Alan Beardall. And Alan Beardall was a chiropractor in Portland. And Beardall has also indirectly, through Louisa, been my teacher. And those of you who have studied ART with me have to know that the ART is basically the same, it's coming from the same source as the arm length testing that Hans Lechner is using, and it incorporates all the principles that we know of: block regulation, neurogenic switching, the staggering of interference fields. That means like there's the issues in the body are in layers, and you only can work on the first layer first before you get to the next one. The next one, you can't treat the whole enchilada simultaneously. You have to work your way through one layer after another. And there's very few systems. Now, Doug Lieber and some of the cool electric acupuncturists over here have learned also to incorporate those structural things within the testing, to incorporate that. But definitely the world master, and I take my hat off to him, is Hans, which wrote a book on the arm length testing, on all the intricate things that are to know about that. And he published now this book here, which is translated. The title is Interference Field in the Trigeminal Area and their Connection to Systemic Illness. So basically, this is sort of, has instantly become sort of the textbook of biological medicine in Europe. And Hans is not only like a gifted healer, practitioner, thinker, but he's also an incredible writer. And this is one of the best writing you would have ever seen in any medical text. And in the last couple of years, Hans developed, being much influenced by Doug Lieber and other people here in America, in trying to make the arm length testing easier. He developed a computerized way of storing all the vial information, different than the principles we use here in America. We use virtual ways. That means all the computers that have all the vials stored in them basically just use the name of the vial, and the rest goes through your subconscious mind. It has to do the rest of the work. And he's found another way based on very sophisticated physics to develop a way of storing the information of the vials in a computer, and develop a whole system around that, which I bought and I personally feel is far superior to any system that's been out there so far. And I know as part of today's talk is going to introduce that we also have set aside some time. We're going to talk about that later, either tonight or tomorrow after the main conclusion of the course, and on Monday, where he's going to give some first introduction to the use of this instrument. And the Academy of Neurotherapy has a workshop scheduled with Hans in June, it is? July. In July, it's a 3-day workshop where people get completely trained in the use of the system. So this, so you don't get nervous that you have to learn everything today. So there's some other things set up. So I think I've said enough about you, huh? Hans, why don't you come up?
Thank you, Didi. You said everything about me which is worth to be known. So I can close now and go home again. Well, before I start, I want to thank to the holistic German Secret Service in this country, consisting of Mrs. Issels and Dietrich. And thanks to Carol and Adarana, that's the reason why I'm here. Now, the subject. Okay. The subject is, I have to talk about, is dental disturbance fields. And in the second part of this afternoon, I want to give you an introduction in a systemic diagnosis and systemic treatment of these disturbance fields. But first, the question comes up, what is a disturbance field? This is just an attempt of a definition. First, a disturbance field has a total body impact. And second, a disturbance field endangers the order, or we say the coherence, of a living system. This is an example of a disturbance field for this guy in this car, and this disturbance field is endangering his coherence in the same way happens with this guy. Well, these were very visible disturbance fields. But the disturbance fields we have to deal with in our practice in everyday dentistry, they are difficult to detect for two reasons. They do not hurt, and they are in common, they are not visible on X-rays. Now, as we talk a lot about disturbance fields, but as disturbance fields are more or less an energetic phenomenon in their total body impact, we have a very useful technique in Germany. This is the Kirlian photography, or the energetic terminal point diagnosis. It's a very simple technique. We have a high frequency field, and on a photo paper, you get here the meridians of the fingers, and here you get the meridians of the toes. And when you have a patient like this sitting in front of you, she was a young lady, and I saw that Kirlian picture, you immediately know what this patient is missing. Her problem is the missing right big toe. And I asked that young woman with a slight compassion, where did you lose your right big toe? And she said, what? My right big toe? And in the end, her right big toe was there. Her right big toe was, had no problems in circulation, had no problems in its nervous system. But it was very interesting that here where I marked it with a red line, there was a scar on that big toe. And as we practice a lot of neural therapy in Germany, I took a syringe with procaine and injected that scar. And immediately after the injection of procaine into that scar, we made the next Kirlian picture. And you see, abracadabra, the right big toe appears. What does this mean? This means that this scar here, this disturbance field, was able to cut off that whole organ, right big toe, to cut off it from the energetic connection to the rest of the body. It was existent on a physical level, but this toe was not existent on an energetic level. Now, please have a look at the fingers. You see that the fingers have a very dark, dense luminescence. In the medical or clinical interpretation of Killian pictures, this is a very degenerative picture. So we can say if this patient would stay for another 5 or 10 years in this degenerative state, she might develop some cancer or tumor or whatever. We don't know. And now, after the injection, we have two phenomena. First, we have a localized phenomenon here. That means the right big toe, the whole organ, is reconnected on the energetic level to the rest of the body. And the next phenomenon, the systemic phenomenon, is that you see that the luminescence on the finger meridians, on the young meridians, changed completely. That means by that scar, injecting that procaine into that scar, changed her whole system from a highly degenerative state to an energetically normal state. And this is an impressive systemic effect of taking away that disturbance field, which was the scar on her right big toe. So you see, this is the photographic documentation of a neural therapeutic, we call it second phenomenon. Dietrich, where's Dietrich? Oh, wait.
Lightning phenomenon.
Lightning phenomenon. Lightning, thank you. A lightning phenomenon. Now, going on with disturbance fields. You have here an X-ray. There's a young lady, she is 21 or 22 years old, and she is suffering from bulimia. That X-ray is quite good, but what we see is we have here two persisting first teeth. You see them? Here. But the X-ray here on the apical area of these first teeth is quite normal, absolutely unconspicuous. Nevertheless, when we test this patient for disturbance fields, these two first persisting teeth come up as disturbance fields in the arm length reflex test. What is very interesting is that according to Fall, the lower bicuspid area is connected to the stomach meridian. She has two persisting teeth in the stomach meridian, and she is suffering for 3 years from bulimia. That's a very interesting connection, isn't it? Now, as we tested this, we made a Killian photography, and you see that the stomach meridian here and here on the right side and on the left side is in a degenerative state. The stomach meridian has a big lack of energy in her. What I did next is I made an operation here, took out that tooth, that persisting tooth, because this tooth came up as a disturbance field, and her stomach meridian has a problem. It's not very good to see, but on the first operation, surprisingly, just underneath that first tooth came up a big hollow space. And 4 weeks later, we operated the other side, and here I was prepared, and we filled in a contrast medium. And you see the apices went down to here, and underneath that tooth was a completely hollow space in the mandibular bone. We fill it up with this contrast stuff. And now, when we look at the Killian picture after these two operations, you see that in the stomach meridians, you have a normal, absolute normal energetic state. This was a very new experience for me, that underneath persisting teeth, you have, it's a sort of cavitation, a hollow space, obviously because she is lacking energy in the correspondent meridian. Yeah. Now, here we have a patient, and she can't move for 8 months. Here she has an ischium. For 8 months, and no orthopedic doctor can help her. And she has one tooth with a root filling here. This is the upper, we call it the upper two, the second incisor. And the root filling looks quite nice, and the X-ray looks quite nice. And now the question is, how can we decide whether this tooth is eventually a disturbance field or not? When you make a Killian picture, you see here the right lymph meridian, that's the right thumb, is normal, but the left thumb, that means this is the representative of the lymph meridian, has a highly degenerative state. That means there's a big lack of energy. And when we inject procaine on that tooth, and immediately after we make another Killian picture, that lymph meridian recovers on the energetic level. Thus, we can conclude that this tooth is definitely a disturbance field which damages the lymph meridian. Now, this is a picture. He's a dentist too, and we have here a molar with a root filling, with a bad root filling. There is a cyst, and here's a granuloma, and that's okay. This area here on the left lower wisdom tooth area is quite okay. But I want to show you this example that every one of us, every dentist, would say, okay, these two teeth, the granuloma and the cyst and the sinus and root fillings, we take out these teeth under the aspect of a disturbance field. But when we make a Killian picture, when we make a test, an energetic test for disturbance fields with the arm length reflex test, the area of the lower, we call it 3/8. In Germany, we have the system, that's the first quadrant, that's 1, 2, 3, 4. That's 3/8 is, in your terminology, is number 19. Is this correct? 17. 16, 2, yeah, 17. Oh, yeah, I'm a dentist, not on mathematics. So this area comes up as the dominant disturbance field, although nothing is to be seen on the X-ray. When we make a Killian picture, I show you the Killian picture because we can make visible the problems here. We look at the heart meridian, and on the heart meridian on the left side, that's the left hand, on the left side, you see that little window here with a point in it. And that means there is a disturbance field somewhere on the heart meridian. And now, if you make a neurotherapy, if you give an injection on that area of the left lower wisdom tooth, and make another Killian picture, you see that's immediately gone. That means this area is actually a disturbance field on the heart meridian. So if you would take out that guy, just these teeth, yeah, you would not touch his real problem, because his real problem are not these teeth. His problem is on the X-ray invisible area, the invisible disturbance field in that area.
If you took that into account the number, well, 3A as you call it.
Yeah.
And then in 2 months' time, went back and checked, we could find that these teeth, upper molar and bicuspid, would then be a problem.
Yeah, very good question. Yes, of course. Of course. We take away the first layer, and then the second layer comes up, like in archaeology, you know. Now, this is the X-ray of a patient with heart arrhythmia. And she's a lady about 55 years old, and she has already a date in a big clinic in Munich for an implant of a pacemaker. And now, if you look at the X-ray here, you see here the mandibular nerve coming out, the nervus mentalis, and it's losing a bit in quality by the projection, but this area really looks nice on the X-ray. But when you test this area and you ask the body, is there a disturbance field? The body in the arm length reflex test says, yes, there is a dominant disturbance field. And if you do the operation there, then comes up that in this area, in the whole area that we filled up with that contrast medium, the spongial bone, the marrow bone, is so soft that you can suck it out. Chris is agreeing with that. You don't need a burr. You need a burr for the cortical bone, of course. But you don't need a burr for the spongial area. These operations are doing my assistants with a sucker, not I. And 3 or 4 days later, after that operation, she canceled that date for the implant of the pacemaker. And still 15 years after, she has no pacemaker and she has no heart arrhythmia again. And you see how deep it goes. You see here the mandibular nerve, and you see exactly what Jerry Boucaud says, that this softening bone is going to the mandibular nerve, and very often the mandibular nerve is embedded in this softened bone. Oh God, that's not very good. Sorry. This should be an operation site. That's the cortical area. And what you see here, this is the mandibular nerve, which is lying in that mandibular area without any bony protection, without any bony sheath. That's all gone. And it looks perhaps a bit heroic, but nevertheless, if you have a sophisticated technique, these patients won't have any paresthesia. They have no damage of the mandibular nerve and no numbness. There's another case. Look at this area and look at this area. I think a dentist who is not familiar with our idea of cavitations and disturbance fields never would make any operations in this area. And this is the problem we have. Of course, the other dentists, they look at the X-ray and say, he's cheating you, yeah, because there is nothing. But it's not true, because you can't see the process. This is no proof that there is no chronic inflammatory process. And now we test, and we find out both areas are infected in the sense of a disturbance field. And you see in this area of the lower 6, we filled in the contrast medium. And this area, in the wisdom tooth area, we cleaned it and cleared it in the same way. But still, you don't see that, because the overlay of the cortical bone is so intense that you get no signs on the X-ray that we made an intervention at that site.
What do you use as a contrast?
Well, we take silicone, And we mix up the silicone with barium oxide, with 6% barium oxide, and fill it in, let it it hardens very quickly, and then we take it out again. And we never had any problems. This we do not routinely. Yeah, this is just, I did all these exposures for my own protection, because we have a similar problem in Germany like you have here. And the colleagues say, he's doing that for nothing. And this is to prove the phenomenon. And here you see another picture. And you see the yellow line. The yellow line here is the mandibular canal. And you see how deep underneath the mandibular nerve and the mandibular canal this softening of the bone is reaching. And these are really impressive phenomenons. And when you ever saw this, it's hard to understand why the other ignored that. This is a lower wisdom tooth site, and I make a top like that. And when you take out that and turn it over, you see this fatty, totally fatty, degenerated spongal bone. It's soft. It's coming out these eyes, you know, fatty eyes, like on Mother's Good Home Soup. Doesn't taste like that. And this is typical signs for fatty degeneration. And when you ever saw the structure of that, sometimes it's really hard to take out stuff, hard stuff, for the pathological findings. It's so soft. And when you see this, the consistency of this spongal bone, it's hard to believe that with any machines or whatever it is, you could regenerate that, because there is no structure anymore. Yeah? Of course, when you give injections in that, you diminish the symptoms of that area. The patients feel better, definitely. So in a pre-operative state, when the patient has to wait for a few months for a date, it's quite good to take to the Stabident system and to inject Sanum remedies in there. Yeah. But I doubt that this could be a definite solution of the problem. It's definitely a benefit for the patient, but you have to write, and you have to operate anyway. Oh God, I got a problem with the electric. Excuse me. Where's our construction don't is. Oh yeah, it works.
Did you hit escape? Did you hit escape? I think it'll come back.
No, it works. It works.
It seems to have power.
Yeah, it has power.
The message said that you had no power.
Yeah.
Maybe it's momentarily power.
Okay.
With the pointer. Is the pointer working okay?
Yeah, the pointer's working okay.
Just so small.
Okay, he has power, no?
Yeah.
Strange.
Lights on.
Strange. Okay. Let's go on. Now you know this. This is a picture of Jerry Bacot. And he marked out a very interesting detail. These are these fistulae here. Fistula-like lacuna branches here. Here you have the big site softened, the mandibular nerve embedded, like the picture you saw before on the X-ray. And these are these fistula-like lacunas. This is a contrast medium, and you see here, the scanner was not really good here, and you see here these fistula-like things, you know, formed out. You see here these fistulas. And I like to hear that you call this Chris Husser's 10%. So that means you really have to go beyond 10%, beyond the borderline. And so you get these fistulas, yeah? they won't remain, but you clear them too. And I like that expression. And from today on in Europe, we call this Dr. Lechner's 10% now. There's another patient. She had problems with her shoulder for 2 years. We took out these teeth with root fillings. But please look at the area 3-6, that's 17 again. And the X-ray really looks great. Here you see the mandibular nerve. There is no intervention is necessary here. But when you test, you find the dominant disturbance field not in this area, but in this area. Nevertheless, we took out these teeth, but we cleared that side. And the pathohistological finding in that side was a low malign T-cell lymphoma. Yeah. Although the X-ray was completely clean. And now, who was talking about the lead? Dr. Gordon, you were, yeah. That's I brought it for you.
Thank you.
And this is of that side, yeah, the lower left wisdom tooth area. This is the spectrographic investigation, and let's look at the mercury, the quicksilver. This is not very much higher. Yeah, we have the maximum. It should be maximum in the bone 0.1. And the mercury is 0.26. That's just double. But lead is the maximum 0.5, and we have 9.1. That is 20 folds as much as the maximum of lead should be in the bone. And this is probably, this enrichment of lead, of the heavy metal, is probably the reason why this lymphoma come up. And on the other hand, it's the reason why this side, where this bone is so soft. Because the heavy metals block all the enzymes. You find that in Boyd Healy's website. And these enzymes are massively blocked. And this is the reason why we feed up the patient before the operation and after operation with Wobenzyme. Excuse me?
Go back to the X-ray.
So, back to the X-ray, yes. This one or the one before? Yeah. I don't think that the dentist would get the idea to clear that site, except with a test.
While you're on the subject, this is very, very important. This is why you have to biopsy. The incidence of this, according to Dr. Balku, is 1 in about 800. I have had 2 lymphomas in 12 years. Not myself, but patients, you know. And this is why you have to biopsy this. Stavudent doesn't biopsy. Sound remedies don't biopsy. You have to do this. You can save a person's life by doing this. This person would otherwise died of lymphoma probably had he not found that.
Yeah, exactly. Exactly. And in the end, we found it by a bioenergetic test. Yeah. So we can say, well, we need, as we have no clinical instruments to clear the problem, to find that problem, we must use some strange, weird techniques like kinesiology, like EIV, yeah? Whatever it is.
Thank you. I just want to see that. Get an explanation to where the lead comes from.
Oh, well, that's a big answer. We mostly think it comes from the gasoline, from the petrol.
I have a simple chain. It's called lead check. You can buy it at any hardware store. You touch any window, any bathtub, any glass. If it turns red, it's lead. And this is, we have a big EPA site. We have a little booth over here, and I'll get you the information how to get the lead check. You can test people's homes and find the source.
We have old houses have still lead pipes for the water supply. We have lead in the color, you know, the red color for protecting ironwork, steelwork. That's all lead. Now, another possibility for disturbance fields which are difficult to detect is the chronic sinusitis, or less the chronic sinusitis, more submucosal abscesses in the sinus. And Dietrich asked me to bring that instrument. We use it very often in my office. It's an anthroscope. And we make a little hole here when we take out the tooth, for instance, or we clear the side.
Hang on. Does anybody have a functional laser in your pocket that would show the red dot better?
That's a bit weak.
Very small, yeah.
See it. Somebody's got to have a laser.
Oh, come on, guys. Somebody's got a laser in their
Dr.
pocket.
Rennick had one in his pocket.
Here, I got it.
All right. Hold it out.
George comes through again.
George always comes through.
All right, George.
Oh, God, yeah. Brilliant. Okay, so we make a little hole here and put in the anthroscope. And this is a 75-degree retrospective optic. That means you see now in that angle, you see the base of the sinus. And as Dietrich asked me, I brought that with me. This is okay. You can use this for that, or when you have a vintage motor car, you can use this to check the body, the steel body. Would you like to have that? This is very, very useful, and it's not a big invasion. We think that where is George Mining's laser now? We think that, of course, basically the sinus is the area where the ear, nose, and throat doctors should work. But when we have abscesses and mucosal cysts in the sinus which have a dental, which are of dental origin, yeah, it would be a nuisance if you take out the tooth and leave the cyst there. And then 4 weeks later, you send the patient to the ear, nose, and throat doctor, and he does another operation. That's not very responsible. And this is, when you look with the anthroscope into the sinus, you see here is the, we call it apertura semilunaris. That's the natural opening to the nose. And this is a submucosal abscess in the sinus. And what I do then is, through the little hole we make for the optic, I go inside with a sharp spoon and scratch it so that the pus comes off. Then we control it again with the optic, and in most of the cases we are successful and the patient gets a benefit. The abscess is gone. Otherwise, you take out the tooth, you take out the dental origin of that invisible disturbance field, but you leave that. Yeah? And then, eventually, you have no success for that. And this is, when you took out the tooth, this is the cyst you pull out of the sinus, like that. And then, through that little tiny wee hole, you check again with the anthroscope if the cyst is gone completely and if the rest of the sinus is okay, the mucosa is okay. And when it's all right, you did a good job. If it's not all right, then tell the patient to go to an ear, nose, and throat doctor. Because then this is not anymore a dental responsibility. And this is of a collective of nearly 700 patients. We have a sinusitis, we have cysts in the sinus, or sinus submucosal abscesses in 12.07% of the cases. It did operations in the upper jaw. That's quite a lot, 12%. That means it's not a phenomenon which is very seldom. Now, another non-visible and difficult to detect disturbance field. Just a second.
I just wanted to say something to this, because the American colleagues are not aware of this, but if you have a submucosal abscess in the sinus floor from a tooth and don't operate that abscess very frequently becomes a cause of the next tooth dying and the next tooth dying and the next tooth dying. And I've seen so many people with that. I'm sick of it. And so I'm really urging you dentist guys to start inspecting the sinus and also learn a proper sinus closure, because also, the problem with inappropriate closure of the sinus is also a problem here in the States. Dentists taking upper teeth out, not properly closing the mucous membrane. So maybe you say a few words more to that.
Yeah. And this is a patient with a second relapse of breast cancer. And so you see here these teeth. They are testing as disturbance field. But look at that area in the X-ray. There's nothing. It's totally inconspicuous. But when you operate that and you make the mucoperiosteal flap, you see here amalgam in the bone. You don't see that on the X-ray. It's amazing. Yeah? Well, there's a lot of amalgam in there. And if you just take out the teeth and leave that amalgam, what did you for the immune system of that patient? So with these, yeah, you had a question?
I doubt if it could be pieces of amalgam. It must be the oxides of silver and mercury oxides.
Yes, it can be, and the sulfur or the sulfic connections of that.
So are you suggesting or recommending to take out every amalgam tattoo?
Yes, yes, yes. But the superficial tattoos, they are mostly the same effect. That's why he is absolutely right. You know, when you have the good silver spoons and silver knives at home, and when you have a good dinner with that, with these dishes, what happens? They get black. Because the sulfur coming out from the HS, sulfur hydrogen, coming out of the skin, makes the silver black. And this is the same phenomenon. You know? But nevertheless, we take out the tattoo very thoroughly. But the more difficult and more harmful ones are in the bone, the real amalgam, the forgotten amalgam in the bone. Now, with all these slides, I tried to sensitize you for the problem that disturbance fields are not easy to detect and are not visible, clearly to be seen. And the question comes up, how can we make these invisible disturbance fields visible? And the answer is, we need some sort of bioenergetic testing. We have no choice. And the big thing about bioenergetic testing or kinesiological testing is that we can say, by these tests, we can make the invisible visible. And when we try to define what kinesiology is, we can say kinesiology or bioenergetic testing is the work with that energy that connects the structural, the chemical, the emotional, and the informational levels of the body. With this energy, which is connecting all, not just the organs, the parts, but the levels of the body, we are working by bioenergetic testing. Now, the first part of this afternoon was disturbance field and the problem why disturbance fields are not visible. The next part, in the next part, I want to present you this arm length reflex test, which is just a variation of kinesiology. And I'm using this test for 15 years now. And Dietrich already told you about that. 25 years ago, I started with EIV. And 20 years or 15 years ago, I had the Vega test. And then we have another test in Germany that's called BFD. So I have all these machines, and I was very familiar with these techniques. And I want to emphasize that all these techniques are brilliant. And if you are able to use these techniques properly, please stay with them, use them, go on with these machines. But I had so many machines at home that my wife said, I will get divorced from you when you buy another machine. Though I had no choice and developed one myself. And this is the SCASIS test system. And after introducing you to the basics of the arm length reflex test, I want to introduce you to the SCASIS test system. But first we go to the arm length reflex test. We got it from Raphael von Asche, a good friend of ours. And the difference between the muscle testing and the arm length reflex test is that the patient is lying on his back on a table, preferably on a table, and you pull the arms beyond over his head. And the patient is, throughout the whole test, in an absolutely relaxed state. The theory is very simple. We think we have a lot of sensoric inputs in every second of our life, of course. And when your brain and the parts of your brain which are responsible for that sensoric input is able to deal with this sensoric input, you stay in balance. That means the right side and the left side has the same intensity of neurological input. But if the sensoric input is so much, so heavy, so difficult, or so chronic for that system, for that patient, you get out of balance just for part of a second. And then the tendons, the muscle spindles, and the Golgi bodies in the right arm and in the left arm, they get a different innervation. They get different intensity of signals. And suddenly, you lose your balance. That means that's very, very simple. You know, when I, in a very archaic situation, when I go around the corner looking for berries and something else, and suddenly a tiger is standing in front of me, what happens? I get out of balance, yeah, because I get a shock.
The tiger gets scared.
He would like me. Tender. And now, about my existence in the next seconds decides the ability to find back my balance. Because only when I find back my balance, I'm able to run away of the tiger. And so this arm length reflex test works with a very, very short and slight disbalance. And so one arm suddenly gets longer than the other one. If this effect comes up, we call this a positive arm length reflex. So it's basically the same when you do the muscle testing. You have even arm lengths. The patient is coming, lying down on the table. You have even arm lengths. And then you give any information to that body which is a stress, which he is not able to handle and to deal with. And suddenly you get this reaction. You pull slightly, and suddenly one arm is longer. This is the same when you have a strong indicator muscle, and suddenly that strong indicator muscle gets weak. And for our test, please remember that it doesn't, it's the same when it's changing from that situation to that, or when it's changing from that situation to that. This is not really positive. The decisive point is just the change in the arm length. This is very important that you remember that. Now, just an example. The patient comes in and the arm length is like that, and you put a vial on the patient, and this is Ostitis compositum by Pascal. And these are nosodes of all these sites, of these cavitation sites. And when you get now a change in the arm length, you know there is a resonance of that body to that information. That means the chronic ostitis is a problem for that patient. So you can presume, he has somewhere in his jaw, he has a cavitation site and chronic inflammation. And if you want to know where it is, for instance, you just give him another information. You make sort of a therapy localization. You knock on the right lower jaw, and you get no change. That means the ostitis is not in the right lower jaw. But when you knock on the right upper jaw and you get a change, you know in this area, or a tooth you knocked on, you made a therapy localization, this is the tooth or the site with the chronic inflammation, with the cavitation. And this is a very simple principle.
Do you ever find the ostitis is not in the jaw at all, but rather in another part of the body with a low-level bone inflammation?
In this vial, you only have jaw ostitis. Yeah, not from the femur, for instance. Yeah, it's just that. So it's very specific.
Where do you put the ostitis?
The vial? Well, you can put it in the hand, or just put it here on the thymus. Yeah. Now, the problem is that a normal and healthy body, when you give this body the information of this nosode, then this body will work on this information and will try to reintegrate that information, because the body definitely wants to find back its balance. That's a natural law. So there is a technique, and I don't know, I think the basic the idea comes basically from Birdal, that we can lock in information. That means we keep this information on the display. No, that's horrible. And the display in the arm length test is just the position of the thumbs. Even, uneven, even, uneven. That's our display. And we keep the information on the display for hours. By a locking procedure, we use the so-called XY line. That means while the information is on the display, we make this line up here with open eyes for the young part of the system, and with closed eyes for the yin part of the system. By that, we get two effects. we freeze in the information on the screen, on the display. It stays there. And we force the body to deliver the pathology of that information onto the display. That means to deliver, in our example, all information that is connected with the phenomenon of chronic osteitis, to deliver this information to the display, so this information is accessible for further investigation, for further testing. This is basically the only you have to remember, that locking procedure, yeah, and that the point is, the decisive point is the change of the present arm length. By this locking procedure, we say we open a specific file. That means we open a specific information. The body has thousands, 100,000 of informations, but we just pick out the information of the chronic osteitis in our example. And then the arm length is the expression of the pathology of this specific file. We have all the information connected with the chronic osteitis on the screen.
Now, are you saying at this point you can take away the osteitis ampule?
Thank you for the question. I would have forgotten about that. Yes, after the locking procedure, you can take away the ampule, and the patient stays like that. Thank you. Now, there are different procedures how we can open a specific file. We can put a vial on the patient, a remedy or a vial. We can use Biedol's hand modes. We can use a therapy localization, for instance, on the TMJ. We can activate an acupuncture point. You take one of these, what do you call it, amalgam condensators. We have these nice round things, yeah? Instruments. You go to an acupuncture point, give a pressure on that point with that instrument, and lock that in. And if you get a reaction, then you have on the screen the pathology of this specific acupuncture point. And of course, you can open the specific file by thoughts and visualizations. You can say, think of your mother-in-law, and you get an arm change like that. Not mine, not mine. And you store that mother-in-law in. And then you have all the pathology that is connected with your mother-in-law on the display. So please remember the expression specific file, and we open a specific file by locking in a certain information. So for instance, what we can do is just another technique. There are a lot of techniques you can use with this tool. The patient is coming, it's uneven. The question is this upper second molar with a root filling, is this a disturbance field, yes or no? Okay, the patient comes. You give him a push on that tooth, and you look what happens. Okay, you get a change in the arm length. That means there is some information that disbalances the patient. So that means this tooth is not okay. There's something wrong about it. But up to now, we don't know. Now you have this. And now you lock that in. So you have on the display, which is like that, that's the display, it stays like that. You have the pathology of that tooth. But you don't know what is the character of that pathology.
Now, do you lock that in with the yin or the yang?
Both, please. Because you want the connections to the yang part and the yin part of that. Always open eyes, close eyes, and again. Okay? You do it twice. Once with open eyes, once with closed eyes. Now we have the patient like that. And when the telephone rings, you can go to the telephone and you buy some stocks or whatever, and then you come back to the patient and he is still like that. He would stay like that for hours. Go down, prepare a bridge in 5 minutes, come back again. Now, the next step is to specify that problem. The only thing you know up to now that this tooth is not okay. But when we use the arm length reflex test or kinesiology for a real clinical diagnosis, we want to know the specificity of that problem. And now we bring the patient in contact with these nosodes. This is upper molar. And we bring it in contact with chronic pulpitis, and we get no reaction. And we bring it in contact with the nosode chronic osteitis of the jaw, and we get no reaction. But with the nosode gangrenous pulp, or gangrena of the pulp, we suddenly get a change. So we know the problem the body has in this part of with this tooth is because there is a gangrena of the pulp. That's what we know now.
Does the change go spontaneously or?
Spontaneously. Yeah. So we know that. Now, the next step is we want to know how severe is that load, that stress. Is the gangrenous pulp in a state where we have to take out the tooth or we have to make a root filling? Or is it in a state in which we can reverse the process by remedies, by neurotherapeutic injections or whatever? And then we take the potencies of this nosode. So we take the nosode gangrenous pulp in a D3. And let's say we get a change with a D3.
Sorry, Hans, remind them it's 3x here.
Oh yeah, sorry, 3x, yeah. And you have a 3x here, and you get a change with a 3x. You know, this is a really severe state of the gangrenous pulp, and you have no chance to heal that tooth. When you get it in a D6 or in a D8, yeah, you know, we try, we have a chance. And by this very simple procedure now, you get a very, very precise clinical diagnosis of the conditions of the pulp.
What is the potency of your test ampules? One slide back. What potency do you use?
Well, it's part of the common nosodes, of the common dental nosodes. You go through that. Yeah.
Is that a mixture? No.
Pardon?
Is that a combination?
No. You have a box of chronic pulpitis, yeah? Or you have, yeah, and you have a box of gangrenous pulp and so on. Yeah. Going back to the arm length reflex test. The arm length reflex test has one big advantage to the straight muscle test. Basically, all these tests are based on digital answers. The body says yes or it says no. That means you have a neutral situation, you give the patient a strain, and it says yes or it says no. You get a change or you get not a change. A yes means, yes, this strain is really a strain for me. If it stays even, the body says, no, this stress is no strain for me. That's not a relevant information. Forget about that. And now the arm length reflex test has not only doesn't give you only an information of the quality, it gives you an information even on the quantity of the strain or of the stress. That means when the difference between right and left is very, very long, this is a heavy strain. And if it's not so big, you can say this is a lesser strain. And going back to these potencies, you can say if you take a D3, or if you take a 3x, you get a total even state. If you take a 4x, you would get a change, but just up to here, and with a 5x up to here, yeah? So you get a really, really sensitive scaling instrument. And you can say, this bonus is not so good, that's better, that's it. And this is, again, what we really want to do. We want precise informations, precise testing, precise diagnosis. What we want to do with the system is we want to work like a sniper, not like a big gun, boff. We want to hit into the black point. And this is basically the scale. A D3, a 3x is gone. Yeah. A tissue in a 3x is, in most of the cases, it's gone. It has lost its ability to recover. So you have to operate, or you have to extract the tooth. And if you have several 3x's, or if you have a D2 or a D1, you have no chance. But if you have a D4, 4x, 5x, and so on, you can try with your remedies. And you should try, and you have a chance. So you exactly can say, is it worth to try, or is it not? OK. So this was part 2. I think it's, yeah, question?
Different operators do this, will they get how close to the same result?
Well, this is a very difficult question. We must be aware that all these energetic testing is not objective. The bioenergetic testing is an individual interference between the tester and the doctor. And in case, well, I'm convinced that I can help a lot of people by clearing the cavitational sites. So it's no wonder that I find a lot of cavitations in the patients. If you never heard about cavitational sites and never heard about her pathologic effects, but you are convinced that the candida in the intestine is the real problem of the human beings, of our civilization, then you will find candida very often. But that's quite natural, because that's your way to help this patient, yeah? And the other one is my way to help that patient. I think this is a way back to a real humanity in medicine, to an individual relationship between patient and doctor, and not just a prescriber of some chemical pharmaceutical remedies. Did I answer your question? It was a difficult but a very good question. It's difficult to answer. Yes, that's what I want to say, yeah. Other questions? No, everybody's hungry? Yeah, yeah.
Are you familiar with the ART testing that Dietrich teaches? The autonomic response testing, muscle testing?
Yes.
This sounds like it's very much the same, but
Exactly.
is this subject to the regulation disturbances or the switching that we learned?
No, the thing is, of course, we test the regulation in this test too, in the same manner. Yeah, just the tool is different. We don't use these muscles. Yeah, we use the arm lengths as an indicator, but basically it's the same. Yeah, and I do not talk this afternoon about the blocked regulation because time is too short. But of course, it's included, as Dietrich said before. We have the same principles, yeah, and the same basics and the same origins. There's no problem. Okay, we are back in at 4 o'clock, half an hour. Okay. Thank you. Don't switch it off. It's the cooling.
Okay, oh, I'm
the
sorry.
lamp, the
Okay.
lamp.
Okay,
lamp.
okay, good
Switch
point.
it on
Thank you,
again.
thank you, thank you.
So-
Okay, yesterday it burned, the other one burned out, so you may have to get F8 again.
No, 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 leave it. No, no, it's okay, it's okay, it's okay. Don't switch it off. Don't switch it off.
Don't stop it.